I'd really like to thank you all for being with us today. It's an honor and great pleasure. My name is ا.د.خليل, Professor of Ophthalmology at Malta University. Today, I'll be discussing IgG-related orbitopathy. Well, it all happened actually in 2011 when I encountered a 12-year-old female with proptosis, sudden proptosis. Orbital biopsy at that time showed numerous presence of plasma cells in that is stained immunologically specific for immunoglobulin G4. And the nice thing is that she responded well to steroid. It really disappeared rapidly. However, she came back with recurrence. And this is actually a stigma of immunoglobulin G4 related orbitopathy. As an introduction, immunoglobulin G4 orbitopathy is part of the IgG-related disease. What's an IgG-related disease? This is a disorder that affects multiple organs that we will talk about. The first one to be discovered was the pancreas in 2001. However, by a Japanese study, however, later the orbit was discovered to have IgG-related disease as well, and that was in 2004, 2005, and then case reports actually came along. We did a study, IgG-related orbitopathy in 2011 or 12 case series in Vancouver, Canada. At that time, the disease was not well known to many. So this is a systemic fibroinflammatory disorder where you have a lot of fibrosis, you have numerous mast cells in the body, and IgG4 production. The diagnostic criteria has to do with 2 out of 3. Either you have a clinical picture or an imaging correlates with positive blood test of immunoglobulin G4, and finally histopathological biopsy, which correlates with the presence of IgG related cells. Okay, so epidemiologically, this is a disease of males, usually older males, around 3, let's say, to 8 to 1. And it's, however, immunoglobulin G4 related orbitopathy is almost equal. The peak incidence is between 55 and 70 years, and this is a disorder that is associated with patients with chronic asthma. Patients with asthma, allergic rhinitis, and there is a rare syndrome called adult onset asthma and periocular xanthogranuloma, which is very peculiar to be seen in those patients. So IgG4 related orbitopathy has patients, they have an increased risk of non-Hodgkin lymphoma. So even if you treat those patients, it's very important to follow them up because they are at higher risk of malignancy. Okay, so pathologically you can see the presence of dense fibrosis with dense lymphatic infiltration, as you can see here. The fibrosis tend to be like storiform, like it's a storm, tamam, storiform fibrosis, and you can see some areas of obliterative phlebitis. So the clinical picture can intermingle with Wagner's granulomatosis or granulomatosis with polyangiitis, as you today name it. And any phlebitis like venulitis picture, for example, Behçet disease also can come with venulitis, also can intermingle with such a disorder. This is immune staining of immunoglobulin G4. Okay, you can see that well. They are really numerous, and per high power field you can see more than 100. صح؟ And you can count more than 100 of those. This is a biopsy of the lacrimal gland. So if you see a biopsy of the lacrimal gland, which is more than 100 immunoglobulin G4 per high power field, then this is immunoglobulin G4 related orbitopathy or related disease. So the clinical presentation is mainly dacroadenitis, which accounts for 80% of the clinical picture. In the old days, in the old books, if you read, there is something called Mikulicz disease. Mikulicz disease. What's Mikulicz disease? This is bilateral lacrimal gland involvement with salivary gland involvement. احنا كنا بنحفظها حفظ صراحة. But with time, we found that this is actually related to immunoglobulin G related orbitopathy. هلا كمان حتطلع يعني حتشوفوا بالكتب، ما بعرف اذا لسه بدرسوكم او لا. Riddle's thyroiditis. Riddle's thyroiditis is actually immunoglobulin G4 related orbitopathy. تمام? So it rhymes. So we have like some diseases we tend to just memorize them, but we found at the end that they are actually part of a larger, bigger problem that really rhyme together, and the treatment is well organized for that disorder. Okay. So what is differential diagnosis? So differential diagnosis, the most common cause of proptosis is Graves' disease. So this is actually the first disorder that you think the patient might be having. But there are actually a lot of stuff that doesn't go with thyroid eye disease. The first is the age group. Usually thyroid eye disease is a disease of the young, but it can happen in older patients. We have to admit that, but to a lesser extent. So older patients, you have really to to keep this in mind. Presence of proptosis, diplopia, restrictive extraocular motility actually is a common share between immunoglobulin G4 and Graves' orbitopathy. Compressive optic neuropathy is rare in immunoglobulin G4 related orbitopathy. However, it may happen, especially if you have inflammation of the infraorbital canal. Inflammation of the infraorbital nerve and infraorbital canal will enlarge. If this really enlarge a lot, it will cause compression on the optic nerve in this case. Systemic association involvement is very common with immunoglobulin G4 related orbitopathy. As we have said, salivary gland is the most commonly seen, lymph node, let's say enlargement, the pancreas is involved in 20%, and the important thing is that they are steroid responders. Once you give them steroid, it disappears as if the tumor was not even there. However, relapse and recurrence is very common after stopping the steroid. Good response to the steroid is very important, and it really marks that this patient has immunoglobulin G4 orbitopathy. Unlike Graves. Graves, they really respond well, they improve, but they don't disappear. The disease does not disappear. So let's talk about the differential diagnosis of this disease. The first is granulomatosis with polyangiitis, formerly called Wagner's granulomatosis, Sjogren syndrome, sarcoidosis, lymphomas. Okay, always keep non-Hodgkin lymphoma in the list. Orbital infections, تمام، خاصة bacterial أو fungal infections, fungal اللي هو زي mucormycosis، تمام. Thyroid related orbitopathy, and finally idiopathic orbital inflammatory disease. Now, in the old days, idiopathic orbital inflammatory disease was a huge entity. Now 50 to 60% of that entity went to immunoglobulin G4 related orbitopathy. Okay, and the rest is now more or less limited to the presence of myositis. تمام? Myositis and so forth. And maybe like 5 to 10% are still unknown. Imaging is very important. Okay, MRI demonstrate the presence of iso-intense lesion on T1 or hypo-intense lesion on T2, which is homogeneous, and it can be enhanced with gadolinium scan. So the let's say the diagnostic criteria for the disease has really evolved in 2012 and 2015 and 2019. In 2012, the clinical picture was one of the criteria, and it has been omitted in 2015, where imaging was substituted the examination. Still, the hematological examination is very important. The presence of more than 135 milligram per deciliter of immunoglobulin G4 in the blood. Okay, and the histopathological examination. Through histopathological examination, the three categories that we talked about: stormiform fibrosis, presence of plasma cell infiltration, and obliterative phlebitis. Okay, the presence of high power field, okay, high power field plasma cells, immunoglobulin G4, for example, more than 10 immunoglobulin G4 high-powered cells in regular tissue, but in the lacrimal gland specifically, you really need 100 cells in order to diagnose immunoglobulin G4 related disease. So in 2019, they added more to the criteria. 2015, the addition of extra ocular manifestations. For example, the pancreas, the biliary tract involvement, the one we talked about, the orbit, major salivary glands, lacrimal glands, and the kidneys, the lungs, aorta, and large vessels. That's why it intermingles with مثلا Kawasaki disease. It intermingles with polyarthritis nodosa, Wegener's granulomatosis. It's an arthritis disease. تمام. بعدين Pachy and meningitis, and the thyroid gland. Renal thyroiditis. So some of those patients, they come with hyperthyroidism. Okay, the patient came with hyperthyroidism, he has proptosis. The first thing that jumps into your mind is thyroid eye disease, but you don't put on the differential diagnosis immunoglobulin G4 related orbitopathy. So once you give them steroid, the thyroid gland regulates, things are fine, they don't need carbimazole. So the reaching a diagnosis is very important. This really rings a bell. If you have like a lesion on the CT scan, will you go for a biopsy? I say yes. If you have an atypical picture of thyroid eye disease, go for a biopsy. Once you have the diagnosis, you can get a better treatment. And you have to understand something. Once you give steroid, all the clinical signs and clinical picture will disappear. So you are lost. So always, before starting steroid, start with the correct diagnosis. Once you have it, you are on the safe side. Okay, there are some criteria that goes against immunoglobulin G4 related orbitopathy. Fever, for example, presence of fever, beta symptoms هذولا, these are more for malignancy, صح? Diagnosed malignancy, rapidly progressive disease not typical of immunoglobulin G4 related orbitopathy. Immunoglobulin G4 related orbitopathy is a slow disease, it's not rapid. High titer مثلا of anti double-stranded DNA, anti-rheumatoid factor, C ANCA, P ANCA, صح? This rings the bell that it might be another disorder, صح? Malignancy, confirmed, for example, that strongly, in strongly suspected patients, and the presence of a known autoimmune condition. So poor or absent response to steroid. Poor or absent response to steroid should ring a bell. Okay, it should ring a bell, and it should stop you from doing the going with the diagnosis of immunoglobulin G4 related orbitopathy. Treatment. طبعا steroid is the mainstay treatment, and they usually respond well. Usually we give them high dose prednisolone, 0.6 milligram per kg per day for 8 to 12 weeks, and then we taper that. The thing is that they have an excellent response within almost 100% of patients, but relapse is very common. Relapse is common, and it is reported to be as high as 70%. So some patients actually, and that patient that I showed you in the beginning of the lecture, I had to put her on steroid, let's say between 5 and 10 milligrams, between 5 and 10 milligram dose for around 5 to 7 years. طبعا I lost her, I lost contact with her because she's living in Palestine. But this is actually what happened with her. New drugs, for example, rituximab. Rituximab depletes CD19 cells, all B cells. So the immunoglobulin G4 count should decrease. طبعا with their study, they found that the relapse is very rare, almost less than 10% of patients. Okay. طبعا surgery might be used if you have, for example, fibrosis or optic nerve compression, but early treatment carries a very good prognosis. Okay, I had another case in 2016 for a patient. I did for him evisceration, and he was doing fine. He was wearing his prosthesis, doing well. However, the problem came later, after 5 to 6 years, when I found that there is a mass behind the prosthesis, and it's pushing the prosthesis out. So when I took actually a biopsy of that mass, it was immunoglobulin G4 related orbitopathy. This is actually the first case reported to have immunoglobulin G4 because maybe, assumingly, allergy to the prosthesis material, which is just acrylic. This is the one that we use for every patient. And I thank you so much for your kind listening. Thank you.